Hello, everybody, and welcome to this edition of Gastrointestinal Endoscopy Author Interview Series. My name is Sandro Sferrazza. I am a gastroenterologist at Gastroenterology and Endoscopy Unit of Civico Hospital in Palermo, Italy. Together with my colleague Giulio Calabrese, I am pleased to present the results of our study entitled Stenosis Development After Circumferential Colorectal Endoscopy Submucosal Dissection, a multicenter analysis of predictive factors and outcomes. This study was conceived and coordinated at our institution in Palermo and involves 29 tertiary referral centers across 14 countries.
Hello, everybody. My name is Giulio Calabrese. At the time of the study, I was working together with Sandro Sferrazza at the same institution in Palermo, where the project was developed and coordinated. I contributed to the methodological design, to data curation, and formal analysis of the study. The rationale for this work arises from a relevant clinical challenge. Although ESD is increasingly used for complex colorectal lesions, circumferential and near circumferential region remain particularly demanding, mainly because of the risk of post-procedural stenosis.
Most available evidence on this topic comes from small single-center series, largely from Eastern countries and often focused on lesions that are not fully circumferential. Data on lesions involving 90% or more of the luminal circumference, especially in Western practice, are poor. For this reason, we designed a study specifically addressing this gap.
We retrospectively analyzed a prospectively collected dataset from patients undergoing colorectal ESD between June 2018 and September 2024. We included lesions involving at least 90% of luminal circumference treated in high-volume referral center by experienced endoscopists. The primary endpoint was the incidence of post-ESD stenosis and its independent predictive factors.
In total, 315 patients were included. Most lesions were located in the rectum, with a median lesion size of 95 millimeters, reflecting the technical complexity of this cohort. Despite this, outcomes were strong, and block resection exceeded 85%, R0 resection was achieved in over 80%, and oncological curative resection in approximately 80% of cases.
Post-ESD stenosis developed in about 1/3 of patients, but with a clear anatomical difference. Stenosis occurred in approximately 38% of rectal lesions, compared with only 12% of colonic lesions. Importantly, all cases were treated endoscopically, mainly with balloon or boogie dilation, and no patient required surgery.
At multivariable analysis, 3 independent predictors of stenosis emerged: rectal location, complete 100% circumferential resection, and large lesion size. These findings indicate that stenosis is a predictable event, particularly in anatomically high-risk settings.
A key observation was that among lesions involving 90 to 99% of circumference, completing a full circumferential resection was associated with a higher risk of stenosis. This suggests that preserving even a narrow strip of healthy mucosa may be protective without compromising oncological outcomes.
In contrast, the colonic circumferential ESD was associated with a lower incidence of stenosis and fewer symptoms. This likely reflects anatomical and functional differences between the colon and rectum, including luminal diameter and compliance.
However, our study has limitations, including its retrospective design and heterogeneity of prophylactic strategies. However, the large multicenter cohort and international collaboration strongly support the robustness and the generalizability of our findings.
In conclusion, ESD is a safe and effective option for colorectal lesion involving 90% or more of the circumference when performed in expert centers. Although the risk of stenosis, especially in the rectum, is substantial, endoscopic management is highly effective, and surgery can almost always be avoided. Most importantly, our data support a tailored anatomy-preserving approach, suggesting that complete circumferential resection should be avoided when not strictly necessary. Thank you for your attention.